welcome everyone. Today we're going to have and hopefully an interactive discussion regarding our new Medicare GME changes. The title of our conversation is really Medicare GME Funding Update for New Mexico. And there's been a lot of changes coming up and a lot of little intricacies, and we'll be talking about that today. I'm John Andazola. I think most of you know me. I'm the program director of the Southern New Mexico Family Medicine Program in Las Cruces, as well as founding chair and current chair of the New Mexico Primary Care Training Consortium, as well as chair of the Graduate Medical Education Expansion Board through HSD. I'm really excited to learn more about these changes. I've been trying to follow it and I'm confused. And I'm glad Lou here is ready to help us discuss that. So Lou, for those of you who don't know, is an Emeritus Faculty member at the University of Wisconsin Department of Family Medicine, where he was actually program director from 96 to 2002. He has extensive expertise in GME financing and rural program development. And he's also provided advanced obstetrical training to local healthcare providers in various parts of the developing world. Dr. Center has served on the panel of the consultants since 2001, and I think that's with the Residency Program Solution through the AAFP. Dr. Center attended Stanford Medical School, completed his family medicine residency, chief residency, and 2-year research fellowship at the University of Missouri at Columbia. Dr. Center, welcome, and let's get the ball rolling.
Thank you. This updating everybody on the intricacies of this has, sort of driven my post-retirement professional life since December. So, it's a somewhat evolving situation, but there's some important stuff. This is, you're going to get a copy of these slides, so, and of a couple of Excel files that will be helpful to you if you want to dig into this. But here is some contact information. We're going to talk basically about the Consolidated Appropriations Act changes. The act was passed the end of December of 20, and then, the final rules didn't come out until December of 21, actually with a comment period, and then they're kind of final. There's 3 sections that affect GME, and we'll get into it. This is Medicare. Medicaid has its own issues and opportunities, which New Mexico has taken really kind of full advantage of. So I believe there'll be another session talking about what's available through Medicaid, both to get technical assistance, develop a program, and actually get paid while you're running a program. You don't have to read this. I put a lot of stuff. There's sort of an evolving textbook of stuff in the appendices. We're not going to talk about any of this. But there's stuff in there's goodies in the appendices if you want to drill down on any of this stuff. So here's what we are going to talk about is these 3 sections. Section 126 basically allows for the granting of 1,000 new GME slots in the country, 200 per year. And there's no process of applying for those. Section 127, there's a lot of relief for rural programs, which is exciting and relevant to New Mexico. And then Section 131 is trying to help hospitals that got like inadvertently low PRAs or low caps reset them. We could talk a little about what that even means, but that's also a relief for many hospitals that makes it possible for them to do GME where they couldn't before. So diving in, Section 126. This is of the 3, I think the least impactful. And you're dealing with a situation where the deadline for this year is March 31st, so it's already passed. So there's not a lot of hurry to do something about this. But it gives 200 slots a year for 5 years, no more than 25 for one hospital. I'll tell you, no hospital is going to get 25. You can get up to 3 slots for family medicine or 5 for general surgery. It's the length of the program. So if you got 3 slots for family medicine, you could increase your program by one, because once you're mature, if you went from 666 to 777, you would need 3 slots to pay for that. Needs to be new positions. There's this likelihood of filling criteria, but they don't really mean that you can successfully recruit. They mean, do you have ACGME approval to do that? There's supposed to be not less than 10% in these categories, including rural, overcapped hospitals, which is kind of going to be everybody who applies. States with new medical schools, which New Mexico is one, and then HPSAs. The bottom lines, this is the only other slide I'm giving on this, and a lot's in the appendix, is you have to have some progress towards ACGME recognition as either applying to be a new program or applying to make your program bigger. There's an overall HPSA score issue that no matter what these 4 priorities are, they will rank them all by overall HPSA score for the program you're proposing. And that overall HPSA score is for geography and population, not for institutional HPSA scores. For people who are unaware of the intricacies of this, there's geography, population, and institutional HPSA scores. They're not using institutional. So that's a big deal. These are not a lot of slots for the country. The next deadline is almost a year from now. And we're going to know really more about what priorities they really used and who actually applied when these first 200 slots get granted, which we'll know about in probably early 2023. And if you want to consider applying, look in the appendix and it gives you a lot of detail. We think this is probably going to be more important as a precedent setting for new slot awards. If there's bills proposing anywhere from 4,000 to 14,000 new slots, I can tell you as an editorial comment, I have problems with this whole way of doing things. But if they pass, then this process will likely be similar. There's no, as you notice from the slide before, there's no primary care mandate in here. And the way they do HPSAs is both a good idea and also a problematic idea. So we'll see how this plays out over the next 9 months, and then you can consider applying for the next go round. But you kind of have to have ACGME process in place to apply. You don't have to have final approval, but you have to have some evidence of progress. So I don't know, John, if there's questions that come up about that, you can interrupt me. I'm going to move to the next section, which I think has more relevance.
Sounds good.
So section 127, I'm just giving, this is a background slide. CMS considers you to be a new program if you are separately accredited and have a new program director and new faculty and new residents. There have been programs, RTTs in the past that were separately accredited but shared a program director with the core program, so they actually weren't considered new programs by CMS. And now there are some changes with section 127 where the issue of separate accreditation comes up, which we'll talk about here in a second. But if you're not a new program, your hospital can't get new GME funding except under this section 127, or if you get 126 slots. And just to remind you all, we're not talking about New Mexico Medicaid, which doesn't, I think, require that you be a new program to get funding. So section 127, this is effective for cost report periods beginning on or after October of this year. So these fiscal years have not started yet. Most hospitals, the fiscal year this applies to will start in July of 23, but there are hospitals that their fiscal year starts in January, and there's some that it starts in October. They're more rare. So they removed in this section the separately accredited requirement for RTTs. And they say they did that. Apparently the New York Hospital Association advocated for this, unbeknownst to us, all of us, so that it would make it easier for like general surgery, medicine, other specialties to do RTTs, because they were having trouble dealing with separate accreditation. So they removed that phrase. And in the process of doing that, they rebranded RTTs as RTPs, rural track programs, which could either be separately accredited or not. They didn't change the fundamentals of RTTs or RTPs. A program or identified cohort of residents still has to spend greater than 50% of their time in a rural place, which we'll talk about in a minute. So what's rural in New Mexico? Well, all the white and light green stuff on this map, basically not in a metropolitan CBSA. This is basically the 2013 map based on the 2010 census. You may note that we've had a recent census, and when that finally gets adjudicated into CBSA map changes, this may change this map. So if you're in the light green or white, you could, if your residents spend time there, they can be, you could consider qualifying as an RTP. So one of the things that is new in this section is you can get a cap increase at both the urban and rural hospitals participating in an RTP, even if you're not a quote new program. It used to be had to be new for the rural hospital to get a cap increase. That has changed. It's more permissive. They used to have this 5-year rolling average thing, which penalized new RTTs. Basically, you would end up losing a year of funding. But now hospitals will be paid each year for all of the claimed RTP residents. That's a good thing.
Lou, there's a question from Charlie. Charlie?
Yeah, Charlie.
I just want to say that if anybody has any questions about acronyms or CAP and other language here, please feel free to either put it in the chat or wave your hand so that we can make sure as we move along that everybody's on the same page.
I do have a couple of slides where I say, what is some of this? I mean, you're right, I use the word cap without defining it, but we're going to get to it. So, but if you're confused, please chat.
Absolutely. And I'll read the chats out, or if you guys want to interrupt, that's fine. Either way, we'll make sure we get to the questions.
Yeah, it's a nicely small group in the sense that, this can be more interactive. So I'll sort of move along until I'm interrupted, and feel free. So this is new under this section that RTPs can basically expand, not directly, but sort of indirectly. What I mean is, if you have an RTT, now an RTP in a rural place, you can start another one in the same place with the same hospitals in a different specialty. You actually could do that already. Most RTTs are family medicine, but you could start an internal medicine or a psych RTT in your same town, and your hospitals, rural and urban hospitals, would get a cap increase. But now you can start one, this is new, in the same specialty in a different community, which is new. Now, it's not entirely clear what defines a different rural community, but we did clarify with CMS, at least with Michelle Krieger, that if you start a family medicine, you already have a family medicine RTT, and you want to make it bigger, you could have a clinic in a different town, but use the same urban and rural hospitals and get a cap increase, which is, I think, easier to do than starting in an entirely new rural hospital, new to GME, and a new clinic. We pushed to have them say, well, you can expand your current one, because that'd be the easiest thing to do. And they didn't like that. So the next three slides are, if you're doing this, you need, because you're not separate, particularly if you're not separately accredited, how are they going to know which of your residents are in the RTP and which aren't? Because they're all like in the same, accreditation, under the same accreditation umbrella. So if you do this, and you can save this for later if you do it, is you have to submit to your intermediary. A MAC is a Medicare administrative contractor that hospitals submit their cost reports to the MAC. The MAC reviews them, they audit them, they say they're right or wrong. So the MAC needs to know what you're doing. So you have to, particularly if you're not accredited, you have to separately accredited, you have to actually be accredited as a program and show that this is either your first RTP or you're adding additional sites or you're making a separate RTP and where they're getting trained. So you have to kind of segregate the residents on your cost report, or at least inform the MAC about them. They want rotation schedules, as you might imagine. They want those anyway. The IRIS system, which is how hospitals claim residents, really requires like, what is a resident doing every week, and where are they and who's claiming them, hospital-wise. And then for cap setting, because the whole point of doing an RTP or a new RTP is to get money to pay for it. So they will cap that out at some point. You have to deal with the segregated cohort of resident issue to get that cap assigned. Again, I use the word cap without defining it. I'll talk a second here about type of hospital, because there are different types of hospital and it matters. The IPPS hospitals, Charlie and I probably remember before there were DRGs. That's a prospective payment system that Medicare uses to pay for hospital care without paying it on a cost basis. They say if you're a hospital taking care of complicated pneumonia, this is how much money you get, regardless. So those are called IPPS hospitals. And they're the hospitals that get Medicare GME funding through what we call DGME and IME. That's the biggest amount of money paid for graduate education in the planet. So a big deal. There are some subtypes of IPPS hospitals in New Mexico, sole community hospitals and rural referral centers. I do want to talk about that. And then there are critical access hospitals, which are not paid through the prospective payment system. And so they actually don't participate in the Medicare DGME IME funding system. But they can participate in GME through a different mechanism, which I will tell you about. Rural referral centers. Well, this has become a big deal, a bigger deal than I thought. What happened is many large urban hospitals in the country and in New Mexico got reclassified at their request as RRCs. And they did that because they figured out a way to maintain urban wage indexes. It used to be if you reclassified as an RRC, you had to take a rural wage index. So CMS lost a lawsuit about this. So urban hospitals can now convert to RRCs and then partially convert back just to get the urban wage rate. And this is a big deal. So there's this 340B drug pricing, and there's been some kind of almost scandals about this. Hospitals can get drugs at a lower rate and then turn around and sell them at the standard rate. So it's actually very profitable. That may be the actually most profitable thing about it. They also get a 30% IME cap bump. So if you are Massachusetts General Hospital, which by the way is an RRC now, or the University of Chicago, or all the big hospitals in Albuquerque, your IME cap went up by 30%. Amazing. And if you start new residencies that are new to your hospital, you can build that IME cap further. We can talk about how this affects RTPs, but the bigger issue is what's happened that all these hospitals converted. There's over 700 nationally RRCs. Salt community hospitals are another category of IPPS hospitals. They have some certification real similar to CAH's, critical access. They get a cost basis form of payment called the hospital specific rate. And if it's larger than the federal rate, which it almost always is, because otherwise, why would you become a salt community hospital? If the hospital specific rate is larger, then they don't get IME. They get the federal rate, they get both IME and DGME. If hospital specific rate, they only get DGME, but they do get IME for Medicare Advantage. So some parts of the country, like the hospitals, have no Medicare Advantage, so it's no IME. In New Mexico, there's significant Medicare Advantage, but it's not all of the Medicare. I'm going to show you the hospitals in New Mexico here after I go through this. There are other subtypes of IPPS hospitals. I'm not going to talk about them because you don't have them. So they're in the appendix. Critical access hospitals are not IPPS hospitals. And the bottom line is that now, after 2019, time residents spent in a critical access hospital can be claimed by an IPPS hospital if that hospital pays resident salary and benefits. So it's allowed RTPs to function with a critical access hospital partner or new residencies to have rotations in critical access hospitals and still have an IPPS hospital where the big money is claimed them. In the appendix, there's a way you can directly claim expenses and get paid part of the cost. It's rarely used because it's way less money. But if you're pursuing that route, I give you sort of how to do that. Those are the types of hospitals. So if you look at this, this is sorted by average daily census, this up here. So you can see that all the big, really, essentially all the big hospitals in your state have become RRCs. And in the process, got a 30% IME cap bump, which is why maybe some of them are more interested in starting new residencies. There's only 7 salt community hospitals. There's 11, including some RRCs that are both. So it's an issue in the state, like how reimbursement works for salt community hospitals. So, you may be one of these. These are all your critical access hospitals, at least as of yesterday. Again, we used to think that a rural hospital was a rural hospital in a rural place. Now you can have a rural hospital in an urban place and an urban hospital in a rural place in terms of the category of the hospital versus the geography. So the place a hospital is drives DGME and the category drives IME. I'm not going to spend much more time on this. If an RRC is your urban partner in an RTP, then it can work if you, particularly if you separately credit the RTP, because they'll get a cap bump through 2 mechanisms. One, because it's a new program and they're a rural class hospital, and also because they're the urban partner in an RTP.
Lou, I have a question about when is it a new program? So we have several programs that have recently started and growing today. Would they be classified as a new hospital?
Yeah, you're a new program when a hospital first claims residents from that program. You have to be separately, you have to be a quote new program, meaning separate program director, separate core faculty, separately recruited residents. That makes you a new program. Under this section, you don't have to be separately accredited. You don't have to be a new program to be an RTP. But if your urban hospital is a rural referral center, you should be separately accredited. I don't know if that answers your question.
No, absolutely. I think the question I was asking is when does it happen? And if we haven't, it's part of an expansion. We're a new program. 1+2, whatever. But we haven't claimed those residents yet because they haven't started yet.
Yeah.
Then they would fall under that. Okay. Very
Yeah,
good.
there's some tricky business about October of 22. Like there's a lot of new programs that are like in their second year in their cap building, and there are issues with them qualifying basically, which you kind of have to dig into if you're in the midst. So a lot of it has to do with when was the this actually is more for 131. When did a resident from the quote new program first start working at that hospital? It's not really an issue for 127, but we'll get into that.
No, thank you.
No problem. Yeah, I should have done this earlier. So what is this per resident amount of which you speak? So PRAs are the driver for the DGME payments. And it's a CMS defined term, and it's used in other contexts that means different things. Like the THC program, Teaching Health Center program, uses that term to mean the whole payment. The IOM report from years ago about reforming graduate medical education uses the term and it means something else. What a PRA is in the way you should always think of it is it's a set figure for a given hospital. It can be high or low depending on lots of factors. Once it's set, it just inflates. It sort of is trying to approximate the direct cost of the residency, but it actually underestimates them. And it's always, what the hospital gets paid is not the PRA. They get Medicare share, Medicare bed days versus total bed days. So it has a specific meaning for every hospital. A cap also is a CMS defined term, and it's a set figure for a given hospital determined after the 5th year when the hospital starts claiming residents. So hospitals get capped. And if they're an urban hospital in an urban place, they can't increase that cap unless they get Section 126 slots or a nearby hospital closes, or there's a national redistribution, which won't happen without new legislation. So caps can be increased when a rural hospital starts a new residency. It's not really a limit on how many residents you can train, it's just how many that Medicare will pay for. And many hospitals train more residents than their cap. They just, sort of eat the cost basically, or they're training residents in fields that are lucrative. Like it's not hard to justify starting a gastroenterology fellowship and not getting new Medicare money because the billings are so high. New Mexico Medicaid has a different system. So this is background to the 131. We have time, I don't know if people had questions about 127. I think this is a big deal for New Mexico, actually. Like you have some opportunities you didn't have before.
I think one thing for 127 that's unique for New Mexico is New Mexico so for instance, if you live in Las Cruces, you can drive 30 minutes, 40 minutes and be in an underserved community, which is core CBSA, that is has a low score. So residents could do a significant amount of training in communities greater than 50%. And I know the question is whether or not how that would be defined, not necessarily starting a new clinic, but actually doing outside training in that hospital or in that community.
Yeah, it's physical presence in a healthcare setting. There are RTTs that have no rural hospital. All of their rural time is done in clinics. So it's one of the nice things about RTTs and RTPs is it says you got to train them in a rural place, not like in a rural referral center in the city. Like you have to train them in a rural place, over 50%. And
I think I think that alone adds a lot of opportunity for New Mexico for sure.
Yeah, and you can cohort a group and define them as RTP without getting separate accreditation. And sometimes that's helpful depending on who your urban hospital is. So I think there's a lot of opportunity. You know, you have an RTP already and you just want to have a clinic in another town, you know, but use the same hospital sort of infrastructure. So I think there's a lot of creativity that can be applied here.
That's great.
So the Section 131 reset process. So why did this come to existence? Well, because of Green Bay and Lakeland, Florida. Why is that? Well, there are many GME naive hospitals, often rural, that were nice guys and let residents rotate there from a distant residency, never claimed them, never paid anything for it, thought they were just, you know, being good citizens. And then when they went to start a residency, the MAC determined, the intermediary determined that they had residents before that they didn't claim. They should have claimed them. So now, since you didn't claim them and you didn't claim any cost, we're going to give you a PRA of nothing, 0. Oh, and by the way, they're from a new program, so now you have a low cap. So this sort of poisoned the well for hospitals trying to be good citizens and take residents for rotations. We call these hospitals never claimers. They're not never trainers. Many of them, some of them are, but they just never claimed anything. And a lot of these hospitals don't even know that they have this problem because they never thought about it. So Section 131, which used to be called the rotator bill, was written to provide, you know, some relief, fair amount of relief for these issues. So these are the rules. You're an old teaching hospital, potentially category A, if you got your PRA before October of 97. And if that was based on less than 1 FTE of claim that year. And then if at some point you train greater than or equal to 1 FTE residents from any established or new programs, doesn't matter, you can apply to get your PRA reset if it's low. If it's not low, you won't bother to do that. If you're in that same situation and your cap is under 1 and you begin training, this is where you get caught, training more than 1 resident from new programs, you can sort of basically add to your cap. And this is where if you started training residents from a new program in July of 20, that residents from that program won't count. So it's quite annoying. So it's a little different for resetting your PRA or adding additional cap. If you're a newer hospital, meaning you became a teaching hospital, you got your PRA after October of 97, then you can reset it if that PRA was based on a claim of less than 3 residents, less than or equal to 3 residents. And if you now train more than 3 residents from any kind of program, new or established, you can reset your PRA if it was low. And if you're in that situation and you start training residents from a new program, you can start adding to your tiny cap. If anybody has questions about that, but these are these category A and B hospitals.
I have one question. So we started a 1+2 program in July of 2020. The residents didn't start until in the other hospital, which is actually category B hospital, until July of 2021.
Yeah,
so
I think you're okay because it's really when the hospital begins training residents, not when the program started.
Excellent.
So they're residents from a new program and that hospital didn't begin training them until 2021. I think you're good with that. You know, I'm not the MAC, but I would, you know, a read of the regs would say they're good.
And that makes sense to me based on our previous discussion about CMS counting when the report is actually being filed. So before these people actually even started on the hospital grounds. So,
So they're not going to be claimed until a cost report starting in July of 21.
Excellent.
And then there's the never claimers, as we call them, and the people who are this was very helpful. So, and this is again, the date of enactment issue. Like, if you're currently what we call a virgin hospital, meaning, or a never claimer, no PRA will be triggered until you start claiming greater than or equal to 1 FTE resident total in a year. So you can squeak along as what we call a tiny trainer under 1 total in a year and not have to claim them and remain, virgin. But if you are training greater than or equal to 1 FTE, you have to claim them, and if you don't, you're at risk for getting a zero PRA. But some hospitals have done, and John, I think you guys did this. They said, we just want to like trigger a PRA and get it done with, like in a planful way. So you can even do that if you're under 1 FTE, if you enter into a Medicare GME affiliation agreement with another capped hospital, and you claim you're like half a resident. So you can trigger getting a PRA, but you don't have to. So these are the never claimers. We think there's a lot of them. In fact, we know there's a lot of them. We think a bunch of them have probably trained residents in the past and maybe training them now. And there's that risk we discussed about getting a zero PRA. We think this helps you, but you got to kind of attend to the process here. There's something called a HCRIS file, which Medicare released in the fall. They actually had before, but it's way more complete. It's a hospital cost report information system. That's what HCRIS means. And it goes all the way back to 95. There's like 14 files, but I made it easier for you. I'll talk about that later. So if there's no entries for your hospital in those files, then you are a never claimer. And the MAC can't investigate further. They can't, even if you say, oh yeah, we used to train residents, even that doesn't get you in trouble. If there's no entries, they're like done. So you're in good shape if you're not currently training greater than or equal to 1 resident. You don't need to do anything. If you look at your HCRIS file and you say, I don't agree, the hospital says, I think this is wrong, then you can file a disagreement, but that has a deadline of July 1 of this year. I will say this again here in a minute. So if you're training greater than or equal to 1, you got to deal with it. And whenever you anticipate setting a PRA or resetting one, you need to make sure in that fiscal year you claim enough costs to get the maximum PRA for your comparison number, because they're glad to give you your actual costs divided by resident if it's lower than that comparison number. I did point out that all these never claimers that were training residents, if their friendly neighborhood urban hospital was merely claiming time spent in that rural IPPS hospital, that's a violation. So there's the flip side of being a never claimer is that if time in your hospital was claimed by some other hospital, they have potential audit jeopardy. There's this little issue that if you're resetting a PRA this year, you can choose either, because you qualify this year, you're training more than the 1 or more than the 3 FTE total. You can choose to do it FY22 or 23. And they don't have this, there used to be this rule about had to be a PRA setting year, had to be where a resident was there in the first day of the first month. They got rid of that, which was annoying, and I'm glad they did.
So I have a quick question about that. So let's say they start 6 months into the year and there's an appropriate payments mechanism, et cetera. Would that, but only 6 months of payment has occurred.
Yeah.
Is that annualized over the year?
Yeah, it's all FTE. It's based on FTE claims.
Okay, perfect.
So if you claim to half a resident, then it's cost divided by half a resident.
Okay.
I'm going to show you these files. I have some New Mexico data that you have access to. You can have the file. And I have this tool for actually looking at the HICRIS data if you're interested in a specific hospital. It basically summarizes all 14 files that would be completely annoying to go through. So this is a piece of a file, but it's probably enough to look at for this talk. The file has everybody in it for New Mexico. You can see that there's one likely we call likely category A based on our analysis. The RRPD, basically HRSA paid for someone in New Mexico who's smart with programming it to, we kind of worked with him to like, which could be likely category A, likely category B. You have to kind of dig into each hospital to confirm that. But so if I was being friendly to the hospitals of New Mexico, these 5 hospitals actually need to look at this. And they should look at it some version of now. Because if they're training more than that threshold, they actually have to deal with it now. And then there's a ton of never claimers in New Mexico. These are, I'm showing you like 8 of them, but there's 36 more of those. I didn't show you that, but it's in your file.
And Lou, you were talking about the importance of doing it now. The deadline is this July, is that right?
Well, if you disagree with the data,
yes,
the deadline is July 1. However, if you're one of these 5 hospitals, or we say we got it wrong and there's actually more than 5 or less than 5, and you're training above the threshold right now, you have to do something about it like this year or next year. Like you have to like start having, if you want to reset your PRA or restart your cap, add to your cap, you need to like look at it now and make a plan. So, the problem is like, say you're this year's fiscal year and you actually been training, 5 residents, but paying for none of them. And having no costs. If you do it this year, you'll have no cost divided by 5. You'll get a 0 PRA. Like you don't want to do that. So this is taking an opportunity to reset it at a higher number. And the never claimers have the same problem about right now. Like if you're above the threshold, which is 1 FTE total now, you have to do something. You really should do something about it now, because you're in technical violation if you don't. The only people who really got to buy in the never claimer world were the under 1 FTE hospitals, which there's a bunch. I mean, it may be that this entire list is under 1. Charlie and I have talked about Presbyterian Espanola, since they're on that list. They've been training some residents, mostly medical students, but they're under 1 FTE total in a year. So good for them, But I don't know, who knows about the rest of these hospitals?
It would make sense in New Mexico that would be the case, because I can imagine a resident going out for a month,
right,
and then being gone for the rest of the year. And so there'd be a 0.1 FTE or 2 FTE. It's rare that a resident would spend an entire year, or there would be residents to spend an entire year in some of these rural places.
Yeah, I mean, we found in other places like, oh yeah, we have residents doing hospitalist rotations from internal medicine program, or oh yeah, we have people in the ER. Like it's actually not hard to get above 1 if you're, playing with more than 1 specialty, or you're close enough to, Albuquerque that, they want to rotate people out there. I mean, it may be that, you have the lay of the land. It may be that like nobody's in trouble, which would be fine. So in summary, we're recommending all hospitals look at their HICRIS data. I'll show you this tool I got here. And if there's no entries and you're currently not training more than greater than or equal to 1, then you don't have to do anything. If you are, you got to do something about it. If you're training more than 1, greater than or equal to 1. And if it looks like you are eligible for a PRA reset, you need to think about this now. And if you're not eligible for reset, you don't have to do anything unless you disagree. And then you have a deadline to disagree. This is sort of all on one slide. And this is like, does this affect you? So the 126 slots, you should consider applying. And John, we talked about it, like if you're overcapped, if you want to start a new residency or expand a current residency and you fit at least one priority category and you have a high population or geographic HPSA score, that's like the main deal. It's going to be, we think there's going to be lots of applications for few slots, and we'll learn more, in 9 months, and it's probably a dry run for next year. For a future bill, that would be a larger pile of slots. Section 127 matters if you're planning an RTP and now considering doing that without a separate accreditation. That's a more complicated discussion than just this. And if you have a current RTP that started before October 1 of 22, but you're still in your cap building, you can take advantage of that rolling average, but you're going to have trouble in the 131 stuff, which we'll talk about in a second. If your urban hospital has never had an RTP and you want to start one, it may be more attractive because you don't need to fit the new program criteria or have a separate program director. Or if your urban hospital has an RTP and wants to expand into a different rural community or involve a different specialty. Section 131 matters if you got a low PRA. If you don't have a low PRA, that part of it doesn't matter to you. And if you're, depending on when you were set, your hospital has never claimed residents, or your hospital has a low cap and is planning to start a new residency. And there's some relevant dates. This is now moving out of the CAA. I don't know if people have questions. I've not been looking at the chat, John, so I don't know if there's any.
No, we're actually doing pretty good.
Well, good. So this is all in the context of starting or expanding residencies. And this CAA stuff is just stuff to be aware of, but there's other things, there's a lot of things to do if you want to start a new residency. So the ruralgme.org, the Rural Residency Program Development Grant, which I know Charlie you guys got one for Espanola. There's some good tools in that, even if you don't get a grant, for how to plan for a new residency. And now there's a Teaching Health Center Program Development Grant through also the Technical Assistance Centers, North Carolina. They have useful tools. You don't, if you are planning to do a Teaching Health Center or thinking about it, there's a lot more details in the appendix. And then New Mexico will be, has its own wonderful opportunities. I think, one of the bottom lines of this, we have no idea how to get the word out to hospitals that they need to do something like this stuff right here. Like, you guys are on the ground in New Mexico. It's in the interest of GME in your state that the hospitals, think about their status, pretty quickly.
I think this is really important, and I do agree. There's a lot of hospitals that are probably even clueless or not even thinking about this issue. But those, and I think I'd like to throw out that the New Mexico Primary Care Consortium will definitely work on some of these issues. If you're category A, B, or a never claimer, we can help figure that out and help move that ball forward. So the reason I'm throwing that out there, not just now because I think a lot of people on the call know that, but I know there's a lot of people that are going to be logging on and looking at this in the future. And so the NMPCTC can help you decipher some of this and help you start moving in the direction where you can address that. All right, we'll let you show us that table, because I think that's really a valuable file that you've sent that you're going to share with us.
Yeah. So let's imagine you are a hospital, one hospital, on that list. Let's look at, Lovelace Medical Center in Albuquerque. So 32, I'm just going to put 3209 in there. So this is all their HICRA stuff. And if you try to look at all the individual files, you'll be thankful that this exists. So if you look at them, we thought they were likely category B. I'm sorry, we thought they're category A. They're the likely category A hospital. So they got their PRA set, early, 97. And this, you can see their PRA kind of inflates. It's not always there. Sometimes it disappears. Sometimes they didn't claim anybody. This is, the HICRA data is messy. And their cap was low, under 1. So, that's their initial cap here. They got a cap bump probably because they did this national redistribution in 2010. But they should qualify for restarting. They could decide whether their PRA is too low. It may not be. Like they have a decent PRA now. They're up to 89,000. But they could do something with their cap. Now, their cap went up for unknown reasons, right? Like if you look here, it looks like it went up in 2010. It may have been that they got recategorized as a rural referral center. They were like an early adopter. Mm-hmm. But, this is just flat out the data from HICRA. So if I was at hospital, I would know my situation, think about my situation, and see if I wanted to do something about it for either a PRA or a cap. But it just gives you all the data, all the messy HICRA data for that hospital. If I'm 320089, you're likely category B. Well, nothing happened here until 2012. And when you got your PRA, it looks like it was your claim was under 3. I don't even know why you got a PRA with a claim of nothing. And then you got a cap, like a super tiny cap. Who knows what that was about? But if you're that hospital, if you're a UNM Sandoval, you should do something about this. You should look at it. Unpack look at your HICRA file, look at the rules, see what you qualify for. And then you can do that for everybody. Like if you're one of these never claimers, 3216, there's nothing here, right? There's nothing here. So you're a never claimer. And if you've been having residents, you want to check and see if you never claimed them, confirm that, because maybe you weren't here 15 years ago. So you can confirm your status. And never claimers are easy because there's nothing in the file. So that's what this tool lets you do. And it has instructions. And here you can look at like the hospital in Green Bay that was responsible for this, and the hospital in Lakeland, Florida that was responsible for this, like why they became category A and B. And there's a never claimer example, which is easy to find because they have nothing in it. So anyway, this is a tool you got if you're going to dive into a hospital.
Thank you, Lou, for sharing that with us. We will definitely be using that here in the state of New Mexico. We're at the end of our time. It's 1:01. I don't know if anyone else has anything else before we wrap up, or anything else to discuss before we wrap up. And again, I think a lot of this information is hard to wrap your brain around, and you have to try it like 5 or 6 or 10 times. And I think we're recording this. You can re-listen to this. The NMPCTC can help with information. We'll spread it out there, and we'll keep working at it, because I've been doing it for quite some time and it's still confusing for me. So thank you very much, Lou, for everything. Any other questions or anybody else comments that people may have? All right. Well, guys, enjoy the rest of your day. Thank you, Lou, for sharing this, and we will move forward and we will share this information far and wide.